Hello my dear students. Now, as a part of the continuation of this ECG lecture series, in this session I will be discussing the abnormalities of the P wave. So if you take the P wave it is the first positive deflection on the ECG, right? So let me just show you that. So this is the first positive deflection within the ECG, right? Now, why is this P wave due to? This particular P wave, it is due to atrial depolarization. Right? It is due to atrial depolarization. Now, if you take the P wave, what is the morphology of the P wave? It is having a smooth surface which is monophasic. Now, what do you understand by the word monophasic? In the sense, the P wave in all the leads, it is having a positive deflection, right? P wave in all the leads, it is having the positive deflection. Now, there are certain exceptions. There are certain leads where you have biphasic P wave, and there are certain leads where you have a negative P wave as well. What are those leads? We will discuss. Now, the next important point here, what you need to know is, what does this particular P wave represent, right? That is your atrial depolarization. But if you take this as the P wave, it has two halves, first half and as well as the second half. The first half of the P wave, it is due to right atrial depolarization, and second half of the P wave, it is due to left atrial depolarization, right? So first half is your right atrial depolarization and second half is your left atrial depolarization. So this is your normal P wave, and I said you the P wave is monophasic, but you see a question. So the question is, in which of the following leads the P wave is biphasic? Lead 2, lead 3, AVR and lead V1. So biphasic P wave, right? How it will be? This is your biphasic P wave, right? This is your biphasic P wave. So this biphasic P wave is seen in lead V1. In lead V1, you have the biphasic P wave. Now, in this biphasic P wave, the first half, it represents right atrial depolarization. The second half, it represents the left atrial depolarization. Right, the second half, it represents the left atrial depolarization. And let me show you the Ecg strip. So this is the Ecg strip with biphasic P wave. Now, out of which I have said you the first half with positive deflection, that is your right atrial depolarization. The second half with negative deflection, that is your left atrial depolarization. Now, after having discussed about the morphology of the P wave, next, before that I have said you that P wave will be having a negative deflection in lead AVR, right? So in lead AVR, the P wave, it is having a negative deflection, okay? And why is that? Let me explain. So, right, you see this image. Where do you place the AVR? The AVR is placed at this point. And how will be the wave of depolarization which moves? The wave of depolarization, it moves from the SA node and then AV node. From here, the wave of depolarization will be towards the apex. That means the wave of depolarization is moving away from the AVR, and that is the reason why in AVR the P wave will be negative, right? That is the reason why in AVR the P wave will be negative. Now, after having discussed about the morphology of the P wave in all the leads, now the next question is about the axis, right? Let me discuss that. So you see this question, normal P wave axis is approximately 90 degrees, approximately 60 degrees, approximately 120 degrees, approximately 30 degrees. Now, the normal P wave will have an axis of approximately 60 degrees. Now, let me explain you why it is 60 degrees. So, if you see this particular image, in this image, you can make out that the wave of depolarization from the SA node, it is moving towards the apex. When it is moving towards the apex, in your hexaxial diagram, right? So you go back to my section on the axis, there I have explained you very detailedly about the hexaxial diagram. So in the hexaxial diagram, the wave of depolarization or the direction of the depolarization in a normal heart is towards more or less 60 degrees. So if you take the P wave also, the P wave axis, it is nearly around 60 degrees. So in a simple term, if the question is asked, what is a normal P wave axis? The answer is 60 degrees. Now, after having explained about the axis, now let me also tell you one important point about the atrial repolarization. So, if you take this atrial repolarization, remember, we don't have any separate wave for the atrial repolarization. And the question is why? Because the potential which is generated by atrial repolarization is very minimal. Right, the potential which is generated by the atrial repolarization is very minimal, right? It is very small. And the potential which is generated by the atrial repolarization is masked by the QRS complex, right? It is superimposed by the high amplitude, the QRS complex. So that is the reason why for the atrial repolarization, there is no separate wave. Right, there is no separate wave for the atrial repolarization. Now you see the question here. So the question is, the amplitude of atrial repolarization is less than 50 microvolts, less than 100 microvolts, less than 1 millivolt, less than 1 volt. So the answer to this question is less than 100 microvolts. So remember this very important point. The repolarization, the potential which is generated is less than 100 microvolts, which is a very low amplitude. And this particular low amplitude is superimposed by the high amplitude, the QRS complex. Right, it is superimposed by high amplitude QRS complex. Alright, now after having discussed about the atrial depolarization, atrial repolarization and as well as the axis, now let me tell you about the amplitude and as well as the duration of the normal P wave. So if you see this question, the amplitude and duration of the normal P wave in the limb leads. So amplitude is different in the limb leads and as well as the chest leads. So the limb leads, they include lead 1, lead 2 and as well as lead 3. So the amplitude and duration of the normal P wave in the limb leads, it is, the options given to you is less than 1.5 mm and 120 milliseconds, less than 2.5 mm and less than 120 milliseconds, less than 2 mm, less than 210 milliseconds, less than 3 mm and less than 110 milliseconds. So the answer to this question here is less than 2.5 mm and less than 120 milliseconds. So this is the amplitude and duration of the normal P wave in the limb leads. So remember this very important point. The amplitude in case of the chest leads, if you see, it is less than 1.5 mm, right, less than 1.5 mm, whereas the amplitude in the limb leads, it is less than 2.5 mm, right, less than 2.5 mm. Now, what do you understand by this word 1.5 mm and 2.5 mm? Let me tell you, I have discussed in detail about like how much is equal to 1 mm on the ECG, how much it is equal to 2 mm on the ECG. I have discussed in detail in my section of the ECG basics, right? Now, and the duration of the P wave, either you take in the limb leads or you take in the chest leads, it is like standard. It is less than 120 milliseconds. So, less than 120 milliseconds duration, it is nothing but it is equivalent to less than 3 small boxes on the x-axis. Right, less than 3 small boxes on the x-axis, okay, because one small box is around 40 milliseconds, right, one small box is around 40 milliseconds, so 40 multiplied by 3, that becomes around 120 milliseconds, all right. So this is about the normal P wave, the amplitude less than 2.5 mm and duration 120 milliseconds. So duration is on the x-axis, amplitude is on the y-axis, and this is in the limb leads, right, this is in the limb leads, okay. Now I'll just show you one normal ECG as well. So this is the normal ECG, and if you see this, the amplitude in lead 2, right, so lead 2 is called as the standard lead. Why? Because the wave of depolarization is towards your lead 2 in your hexaxial diagram. So that is the reason why your lead 2, right, that is the reason why lead 2, it is considered as the standard lead. So in limb leads, the amplitude is less than 2.5 mm, whereas in the chest leads, the amplitude is less than 1.5 mm. So 1 mm is nothing but one small box on the y-axis. Less than 2.5 mm means less than 2.5 small boxes, okay. So this is about the normal P wave, and I have said you that in V1 it is biphasic, right, you see here it is biphasic, right, and you take in AVR, I have said you it is a negative complex, the P wave will be negative, right, and remaining all it is a monophasic positive deflection, right, remaining all it is monophasic positive deflection. So whatever I have discussed now is completely about the normal P wave. Now let me discuss about the abnormalities of the P wave. So if you take the abnormalities, so the first question is, this patient is suffering from mitral stenosis, tricuspid stenosis, aortic stenosis, mitral regurgitation. Now I'll just zoom the ECG as well for you, right? So this is slightly little enlarged. Now when we are discussing about the P wave, right, I'll be discussing mainly about the abnormalities of the P wave in the ECG. Now you see this P wave here, this is your P wave, right, this is your P wave. Now what should be the normal P wave amplitude? Less than 2.5 mm, and if you calculate the P wave amplitude here, it is occupying 3 small boxes. That means the amplitude is more than 2.5 mm, right, the amplitude is more than 2.5 mm. So this particular patient is having increased amplitude of the P wave. And where do you have that? So the options given to you are mitral stenosis, tricuspid stenosis, aortic stenosis, mitral regurgitation. So you will have this in a clinical scenario of tricuspid stenosis, right? You will have this in clinical scenario of tricuspid stenosis. So amplitude more than 2.5 mm in lead 2, this we call as P pulmonale. right? This we call it as the P pulmonale. Alright. Now, what does this P pulmonale represent? Right? Let me discuss in detail about the P pulmonale. So, P pulmonale, it tells that the amplitude of the P wave is more than 2.5 mm in the limb leads, and it represents right atrial enlargement. Right, it represents the right atrial enlargement. Okay, that's a very important point. That means the P wave, it is taller, right? The P wave, it is taller, right? I'll just show you that. So this is the P wave which is tall, that is more than 2.5 mm. That is called P pulmonale, right? That is called P pulmonale. Now, followed by that, you see the similar right atrial enlargement, how it will be in the chest leads, that is in lead V1. So, this is your right atrial enlargement in lead 2. Whereas, if you take the right atrial enlargement in lead V1, right, in lead V1, what is that you will have? What did we discuss about the normal V1? The first half of the P wave represents the right atrial enlargement. So, in your right atrial enlargement, what will happen is, the first half of the P wave, that is initial positive deflection of the P wave in V1, right? So this is your right atrial enlargement. Right, this is your right atrial enlargement. Alright, now the next important point that you need to know is that in right atrial enlargement, the initial half will be more than 1.5 mm. Right, normally how much it is? Normally it is only just 1 mm in normal right atrium. But whenever there is right atrial enlargement, the initial half of the P wave in lead V1, it will be more than 1.5 mm amplitude. Right? Now, after having discussed about the right atrial enlargement, there are certain criteria for the right atrial abnormality. What is the criteria? So, whatever I have discussed in lead 2, whatever I have discussed in lead V1, right? Everything I'll just summarize in one slide. So, in right atrial abnormality, you will have a peaked P wave amplitude of more than 0.25 millivolts. That is called P pulmonale. So, more than 0.25 millivolts. So, that is what? That is equivalent to more than 2.5 mm. Right? And prominent initial positivity in lead V1 or V2. How much is that? More than 0.15 millivolts. So, that is equivalent to more than 1.5 mm, right? And increased area under initial positive portion of the P wave in lead V1. How much is that? More than 0.06 millimeter second. And they will have the right axis deviation of the P wave. You take the normal axis of the P wave. The normal axis of the P wave, it is 60 degrees. Right? Normal axis of the P wave is 60 degrees. But here there will be rightward shift of the mean P wave axis, right? And how much is that? That is more than plus 75 degrees. That is more than plus 75 degrees. Okay, right. So this is about the features of the right atrial abnormality. So let me just show you a small strip of this right atrial abnormality, and then we will do some MCQs on that. Right. So if you see this ECG strip over here, this particular ECG strip, right, you can make out the P wave here, right? So you can make out the P wave here, where the amplitude is more than 2.5 mm, which is nothing but your P pulmonale, right? Which is nothing but your P pulmonale. Now you see the question also. Following are the causes of P pulmonale except pulmonary artery hypertension, tetralogy of Fallot and pulmonic stenosis in right to left sided shunts, tricuspid stenosis, aortic regurgitation. The answer to this question is the aortic regurgitation. Now remember, in which of the following clinical scenarios you will have the P pulmonale is, you will have P pulmonale wherever there is right atrial enlargement. Right, wherever there is right atrial enlargement, you will have this P pulmonale. You take pulmonary artery hypertension, there is increased afterload on the right ventricle, there will be right ventricular hypertrophy, and subsequently there will be increase in your right ventricular end diastolic pressure, and that will exert the pressure on the right atrium, and there will be right atrial hypertrophy causing P pulmonale. And similarly, you take in case of tetralogy of Fallot and pulmonic stenosis. In case of tetralogy of Fallot and pulmonic stenosis, there will be right ventricular hypertrophy, increase in your right ventricular end diastolic pressure, and there will be also increase in your right atrial pressure subsequently. And you take in case of tricuspid stenosis. So in tricuspid stenosis also, there is increase in your right atrial pressure, and thereby there will be right atrial enlargement, there will be P pulmonale. Right? And in case of the other important clinical scenario, what you need to remember is cor pulmonale. Right? That is in case of cor pulmonale. So even in case of cor pulmonale, you will have this particular the P pulmonale. Why? Again, same reason. There in cor pulmonale, there will be right ventricular dilatation and right ventricular hypertrophy. There will be increase in your right ventricular end diastolic pressure, and subsequently there will be increase in your right atrial pressure, and thereby the individual will have the P pulmonale. Okay. So the conditions where you will have P pulmonale, that is in pulmonary artery hypertension, tetralogy of Fallot, tricuspid stenosis, and as well as the cor pulmonale. Now you see the next question. So the question is, this patient should undergo treatment with adrenaline. The patient should undergo surgery, that is PBMV, that is percutaneous balloon mitral valvotomy, treatment with digoxin, surgery, that is coronary artery bypass graft, right? So I'll just slightly zoom the ECG, right? So this is the ECG, and the abnormalities has been circled over there, right? So this is the abnormality. Now, what is the shape of this particular abnormality? It is M-shaped, right? The shape of this abnormality is M-shaped. And what is this called? This is called as P mitral. Right? This is called as P mitral. Now, where do you have this P mitral? This P mitral, you will have this in patients with the mitral stenosis. Right? This P mitral, you will have this in patients with the mitral stenosis. Okay? So, in patients with mitral stenosis, what is the treatment? The treatment what you have to give is PBMV, that is percutaneous balloon mitral valvotomy. I'll be discussing in detail about the P mitral, but before that, you see, this is the PBMV, right? This is your PBMV, right? That is percutaneous balloon mitral valvotomy. So what do we do here? We bring an inno balloon up to the level of the mitral valve, and we keep at the level of the mitral valve, and we inflate the balloon. So that will cause the opening of the mitral valve, and that is called as PBMV, that is percutaneous balloon mitral valvotomy. Now, you will have this particular P mitral in case of left atrial enlargement, right? So in case of left atrial enlargement, you will have the presence of the P mitral. Okay. Now, this left atrial depolarization, what actually is happening here, right? Why do you have that? Now, in left atrial enlargement, which half of the P wave should get affected? The second half of the P wave should get affected. So, the first half of the P wave, it is normal. But second half of the P wave, right? You have the depolarization which will be lasting longer than the normal time, right? So, if you take the duration of the P wave in left atrial enlargement, the duration will be more than 120 milliseconds. Right? The duration will be more than 120 milliseconds. Okay. That is in case of the left atrial enlargement. And one important point you should know is that in left atrial enlargement or in case of P mitral, the amplitude does not change. Okay, so the height of the P wave, it remains within the normal limits, right? The height of the P wave, it remains within the normal limits. Whereas in P pulmonale, the height is increased, but the duration is normal. But whereas in P mitral, the duration is increased, but amplitude is normal, right? Amplitude is normal. Okay. Now, the next important point you should know is about this particular shape of the P wave, which is like M shape. That is called as the P mitral. Now, what is the criteria for left atrial abnormality? So, the criteria for the left atrial abnormality is, number one, there should be prolonged P wave duration. Right, there will be prolonged P wave duration, right? So that is around more than 120 milliseconds, right? That is number one. Next, the prominent notching of the P wave. You see here. So this is a notch. Right, this is a notch. And what should be the distance between the two prominences? That is, there should be prominent notching of the P wave, and that should be most obvious in lead 2 with interval between notches, right? The interval between the notches, it should be more than 40 milliseconds, right? So this distance should be more than 40 milliseconds. So that is when you call it as the P mitral, right? That is when you call it as P mitral. Then apart from that, if you take the ratio of P by PR segment, right, ratio of P in lead 2 and as well as the PR segment, the duration of the PR segment, the ratio between P and PR segment, it should be more than 1.6 to call it as P mitral. What is this? I will discuss, right? We have what is called Morris index and as well as Macrous index. I will discuss both Morris and as well as the Macrous index. And the other point is they should have what is called the P terminal force. Now, what is this particular the P terminal force? That is, if you take the second half of the P wave in lead V1, how much it should be deep? The depth should be more than 2 mm. Normally, how much it is? It is only just 1 mm deep. But in left atrial enlargement, the depth should be more than 2 mm. And the duration, right? The duration, it should be more than 40 milliseconds. Then we call it as the P terminal force. And apart from that, there should be left axis deviation of the P wave. And how much should be that left axis deviation? That is around minus 30 and minus 45 degrees. Right, minus 30 and minus 45 degrees. So this is a criteria of the left atrial abnormality, right? And let me show you that. So this is in your lead V1. Okay, so this is your P terminal force. The duration should be more than 40 milliseconds and the depth should be up to 2 mm, right? The depth should be up to 2 mm. Normally it is only up to 1 mm. But here in P terminal force, you will have the depth of the second half of the P wave in lead V1, it will be up to 2 mm. So this is what is the criteria of left atrial enlargement or left atrial abnormality and the P mitral. Now let me discuss about the two important index, that is Morris index and as well as the Macrous index. That is, so first you see about the Morris index, right? Your Morris index, it is nothing but your P terminal force in lead V1. right? That is your P terminal force in lead V1. That means what? What is the criteria? That is, in case of lead V1, the second half of the P wave, the depth should be up to 2 mm or more than or equal to 2 mm, and the duration of the second half of the P wave, it should be more than, right, it should be more than 40 milliseconds. That is what is your Morris index. That is what is nothing but your Morris index. Okay. Now, after having discussed about the Morris index, now let me take up the question on the Macrous index. You see this question. So the question is, what is the Macrous index for mitral stenosis? The options are 1, 1.6, more than 1.6 and less than 1. So the answer to this question is more than 1.6. Now how do you calculate this particular Macrous index? Right? How do you calculate this Macrous index? That is, so this is your P wave, right? And this is your PR segment, right? This is your PR segment. So Macrous index, how do we calculate? P by PR segment, right? P by PR segment is nothing but your Macrous index. Now you need to know that what is the normal Macrous index. The normal Macrous index, it is 1 to 1.6, whereas if the Macrous index, if it is like more than 1.6, that indicates P mitral, right? That indicates P mitral. And if the Macrous index is less than 1, then that indicates the P pulmonale. Right, that indicates the P pulmonale. So that is what is your Macrous index. So Morris index and as well as Macrous index, it is mainly helpful to decide whether there is right atrial or left atrial abnormality is present or absent. Now summarizing all the abnormalities, right atrial abnormality and as well as the left atrial abnormality. So if you see this, right, this is the summary. Right, so this is your normal P wave, which is monophasic in lead 2 and biphasic in lead V1. And in right atrial enlargement, you have the presence of the P pulmonale, and the first half of the P wave in lead V1, it is enlarged. And if you take in case of left atrial enlargement, right, you have the P mitral, which is the P wave of M shape in lead 2, and second half of the P wave, right, the second half of the P wave, it is more deeper and more wider, right? It is more deeper and as well as more wider. That is what you will have in case of left atrial enlargement. Whereas in biatrial enlargement, you will have both. P mitral will be there and as well as the P pulmonale also will be there. So this is the summary of both right atrial and as well as left atrial abnormalities. And where do you have left atrial abnormalities? That is in case of mainly mitral stenosis. You will have the left atrial enlargement. And how will be the ECG changes? We have discussed that in detail. Now, after having discussed about the right atrial and as well as left atrial abnormalities and subsequent P wave abnormalities on the ECG, now let me discuss how do you assess the rhythm based on the P wave morphology and based on where the P wave is appearing. So, if you see the next question, these questions are like how to interpret the rhythm based on the P wave morphology. So you see the question, what is the rhythm? Normal sinus rhythm, irregular rhythm, ventricular rhythm, accelerated junctional rhythm, right? So you see this is the ECG, and let me just tell you the answer first and then I will explain you. So the answer is accelerated junctional rhythm. Now how to make out this? Right? How to make out it's an accelerated junctional rhythm. So if you see the P wave, it is inverted P wave, whatever you're having here, right? Now, if the inverted P wave, if it is having short PR interval, if it is having normal PR interval, that will decide the rhythm. So, in a scenario of inverted P wave in the ECG, what you need to check? You need to check the PR interval. For suppose, if the PR interval, if it is less than 120 milliseconds, right, if the PR interval is less than 120 milliseconds, then we call it as the origin of the impulse is near the AV junction. Okay, the origin of the impulse is near the AV junction. Okay, so which we call it as accelerated junctional rhythm. So this we call it as accelerated junctional rhythm. Now first of all, you should understand why there will be inverted P wave first. So when there is inverted P wave, right, when there is inverted P wave, it tells you that there is non-sinus origin of the P wave, right? It indicates a non-sinus origin of the P wave. And upon that, if the PR interval is less than 120 milliseconds, then it is called accelerated junctional rhythm. So you have the inverted P wave and the PR interval, it is short, right? The PR interval, it is short, that is less than 120 milliseconds, and that we call it as accelerated junctional rhythm. Now, followed by that, if you take the PR interval, right, if the PR interval is more than 120 milliseconds with inverted P wave, then in such case, we call it as ectopic atrial rhythm, right? We call it as ectopic atrial rhythm. Now, let me show you that particular ECG strip as well. That is, so if you take this ECG strip, you can make out that the P wave is inverted here, and the PR interval, if you calculate, it is more than or equal to 120 milliseconds. So this we call it as ectopic atrial rhythm, right? This we call it as ectopic atrial rhythm. All right. Now, followed by that, in certain ECGs, you will not have P wave at all. Let me show you the ECG. So, if you see this ECG, there is no P wave at all. Right? There is no P wave. Now, when there is no P wave, what does it tells you? It tells that the impulse is originating from the AV node but not the SC node. Right? It tells that the impulse is originating at the AV node but not at the SC node. So when the impulse originates at the AV node, it moves retrogradely and it moves anterogradely. And the impulse which is generated, or the wave of depolarization which is generated due to antigrade direction, where it will depolarize the ventricle, that particular depolarization wave will neutralize the depolarization wave of the atrial origin, right? That will neutralize the depolarization wave of the atrial origin, or it will mask the P wave. So that is the reason why you don't have the P wave. So remember, if there is no P wave, it tells you it is a junctional rhythm. So to summarize everything now, if there is inverted P wave, it is non-sinus origin. That means it is not originating from the SA node. And along with that, if the PR interval is less than 120 milliseconds, junctional rhythm. If the PR interval is more than 120 milliseconds, it is ectopic atrial rhythm. And if there is no P wave, it is your junctional rhythm. Right? Now after having discussed about the various P wave abnormalities in the form of inverted P wave, now let me discuss variable morphologies of the P wave. Right? You see this question? So the question is, treatment to be given for this patient suffering with the COPD. Cardioversion, metoprolol, verapamil, amiodarone? So the answer to this question is verapamil. First of all, what is this ECG? Right? So if you take this ECG here, you have, right, if you just closely observe the P waves, you have variable P wave morphologies. Right? All the P waves, they are not of similar morphology. They are of variable P wave morphologies. Now, and upon that, if you see the rate, the heart rate, it is more than 100. Right? The heart rate, it is more than 100 per minute. Now, we have a clinical entity called as, right? We have a clinical entity called as multifocal atrial tachycardia, that is called MAT. Now, what is the criteria for MAT? There should be more than or equal to 3 different P waves. Right? There should be more than or equal to 3 different P wave morphologies. And along with that, the heart rate, it should be more than 100 per minute. That is what is called as multifocal atrial tachycardia. Right? And we have one more terminology called multifocal atrial rhythm. This is multifocal atrial tachycardia. This multifocal atrial tachycardia, it is more common in COPD patients. And in COPD patients, right, we usually avoid the beta blockers. Right, we usually avoid the beta blockers. So that is the reason why the alternative drug that can be given is calcium channel blocker, that is verapamil, can be given. So this is the ECG of MAT, multifocal atrial tachycardia. Now let me show you a ECG of multifocal atrial rhythm. That is, so you see this ECG here. What is that you are observing? You are having different P wave morphologies. Right? You are having different P wave morphologies. But heart rate, if you see, right, heart rate, if you see, it is less than 100. This is called as a multifocal atrial rhythm. Now the question is, why do they have this variable P wave morphologies? The presence of multiple P wave morphologies indicates that multiple ectopic pacemakers. That means the impulse within the atria is not just originating only at the SA node. It is originating at multiple sites within the atria. And that is the reason why you are having multiple P wave morphologies. Right? You see this image? Right? So here you can make out that this is one particular site. This is another site. This is another site. This is another site. So like this, multiple sites, they are throwing the impulses. And that is what is responsible for your variable P wave morphologies. So here in multifocal atrial tachycardia, SA node is not pacing the heart. Right? SA node is not pacing the heart. There are several groups of excitable cells in the atria that compete to pace the heart. So it is several groups of excitable cells. That is what I have shown you here. Right? So these are all your several groups of the excitable cells. Right? In MAT, as already I have said you, there should be at least 3 different P wave morphologies. And the heart rate should be above 100 beats per minute. And in case of MAT, remember, there is irregular PR interval, irregular RR interval, irregular PP interval. So the rhythm in MAT, it is an irregular rhythm. Right? Rhythm in the MAT, it is an irregular rhythm. Now, the other points are, what are the clinical manifestations in patients with the MAT? So if you take the clinical manifestations, remember, very important, because they have tachycardia, palpitations is one of the very important clinical manifestations, right? And apart from palpitations, if you take the blood pressure of these individuals, it will be on the lower side, because there is like tachycardia, heart rate is very high, and it is like improper contractions. They are not like complete contractions, and that is the reason why the cardiac output also will be reduced. So due to which they can have lightheadedness, right? Due to which they'll have lightheadedness, and they will also have syncopal attacks. Right? They have syncopal attacks. and on examination there is presence of low blood pressure and they will have tachycardia, right? And ECG, it will show the features of MAT, which just now I have discussed. And how do you treat these patients? I said you COPD is the most common risk factor, so you need to manage the respiratory failure, right? You need to manage the respiratory failure. Cardioversion may not be helpful due to hypoxia, and the treatment include beta blockers, and these beta blockers examples are metoprolol, and calcium channel blockers are given, and this particular calcium channel blockers include verapamil, right? These calcium channel blockers include the verapamil. Okay, so metoprolol and as well as the verapamil, these are the drugs that can be given in the treatment of patients with the MAT. And even for recurrent episodes, right, even for the recurrent episodes we give calcium channel blockers, that is verapamil is given, right? Verapamil is given orally to prevent the further episodes, right? To prevent the further episodes. And not only that, you should also know what are the etiologies of the MAT. That is, so if you see this question, drug causing MAT, digoxin toxicity, theophylline toxicity, atropinization, opioid poisoning. Remember, the drug causing MAT is the theophylline toxicity. And apart from that, COPD, as already I have said you, that is the most common cause. Right, COPD is the most common cause. And what is the mechanism? COPD will cause hypoxia and as well as the hypercarbia. Right, so this hypoxia and hypercarbia is the one which will cause the multifocal atrial tachycardia. And apart from that, sepsis. Right, apart from that, sepsis. So sepsis is another important cause for the development of multifocal atrial tachycardia. Okay, next. Now the other important thing, like what you need to understand, is about the atrial extrasystole. Right, atrial extrasystole. Let me show you that ECG. So if you take this ECG, this is the ECG of atrial extrasystole. Right, now why are you calling it as atrial extrasystole? Now you take this is the normal P wave, normal P wave, normal P wave and normal P wave. But before the appearance of the next complex, you have one more complex with abnormal P wave, and here also the same thing. Before the appearance of the next normal complex, there is appearance of another complex with abnormal P wave, and this is nothing but your atrial extrasystole or atrial premature contracture. Right, atrial premature contracture or atrial premature complex. Right, so let me show you the ECG also. Right, let me show you the example, the multiple choice question as well. Comment on the ECG finding: atrial fibrillation, atrial premature contractures, paroxysmal supraventricular tachycardia, WPW syndrome. So if you see here, this is your normal P wave, normal P wave, normal P wave, normal P wave. But you see here, these two complexes, you are having the abnormal P waves. And these abnormal P waves, they are appearing earlier than the next normal complex. So it is a atrial premature complex. And the same way, I will show you the ECGs of the other options as well. But in this option, the ECG, it is suggestive of the atrial premature complex. Right? Next. After having discussed about this, now let me explain you about the atrial premature complex. Like, why are you having a complex earlier than the normal? So, if you see the mechanism, this atrial premature complex, it is nothing but, it is your ectopic pacemaker. Right? It is your ectopic focus and as well as the ectopic pacemaker. So what is happening here is, normally the impulse has to originate from the SA node. But here in case of the ectopic pacemakers, right, but here in case of the ectopic pacemakers, the impulse is originating apart from the SA node, right? The impulse is originating apart from the SA node as well. So that is your ectopic pacemaker. Now, these ectopic pacemakers, what they can do is, they can send the impulse to the AV node earlier than the SA node. When the ectopic pacemaker sends the impulse to the AV node earlier than the SA nodal impulse, that is the point when you will have this premature atrial complex, right? If the ventricle contracts secondary to your atrial ectopics, then in such case you will have abnormal P wave but normal QRS complex. Why normal QRS complex? Because the ventricle depolarization is through your normal conducting system, that is your bundle of his right and left bundle branch. But the atrial depolarization is not through the SA node. The atrial depolarization is through your ectopic pacemaker, and that is the reason why you will have this abnormal P wave. Now, let me show you ECGs of the other options as well. Now, you take the atrial fibrillation. Now, this is the ECG of the atrial fibrillation. So, in atrial fibrillation, what is that you will have is, number one, you will have irregular rhythm. Right? So, if you see there, the rhythm is irregular rhythm. That is why, because you have variable RR interval. And you don't have the P wave. This is not your P wave. What are these waves called? These are called as the fibrillatory waves. Right? These are called as the fibrillatory waves. So this is the ECG of the atrial fibrillation. And similarly, one more option was your PSVT, that is paroxysmal supraventricular tachycardia. Now, if you see this ECG here, you are having the tachycardia, so you can make out there, and the heart rate is nearly around 250 per minute or more than that. And if you take the complexes, the QRS complexes, they are like narrow complexes. So this is the ECG of narrow complex tachycardia, right? This is the ECG of narrow complex tachycardia. Now, where is your P wave in this? Remember, in examples of your narrow complex tachycardia, one of the example is PSVT, paroxysmal supraventricular tachycardia. In paroxysmal supraventricular tachycardia, the P wave, either it merges with the QRS complex or it appears after the QRS complex, right? Depending upon the subtypes of PSVT, which we will be discussing in detail in arrhythmias separately. Okay, so in case of paroxysmal supraventricular tachycardia, you will have narrow complex tachycardia. Now, at this juncture, you should also know how will be the ECG of the atrial flutter. Right, so if you see this ECG, you are having the P wave as, right, you are having a P wave as sawtoothed pattern. So this sawtoothed pattern P wave, where is that you will have? You will have this in patients with the atrial flutter, right? Anyways, I'll be discussing again in detail about the atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia in the topic of the arrhythmias. But here what I wanted to show you is variable P wave morphologies. I wanted to show you when I am discussing the P wave abnormality, right? Now, the last question on the P wave, right? So the question here is, pseudo P pulmonale is seen in hypokalemia, hypocalcemia, hyperkalemia, hypomagnesemia. So remember, the pseudo P pulmonale, it is seen in patients with the hypokalemia, right? In hypokalemia, let me show you all the ECG changes, right? That is, if you take this is the ECG changes in hypokalemia, that is, so this is your normal ECG complex, the first one, and gradually if you observe, there will be flattening of the T wave, right? And finally, there can be also inverted T wave as well. So the first appearance is flattening of the T wave, and there will be also appearance of the U wave. And subsequently, you can observe that there is ST segment depression. And subsequently, you can also observe the QT interval being prolonged. And apart from that, very important, you take the P wave, right? So you are having the P wave which is sharp and amplitude is also increased compared to that of the normal P wave. And this is what is called as pseudo P wave or pseudo P pulmonale. Right? This is called pseudo P pulmonale. Now remember, the true P pulmonale, you will have that in patients with the tricuspid stenosis, pulmonary hypertension, cor pulmonale, tetralogy of Fallot. But pseudo P pulmonale is seen in patients with the hypokalemia. So this is about your P wave abnormalities. So we have discussed the P wave in right and left atrial enlargement. And depending upon the P wave morphology, we can decide the rhythm, that is multifocal atrial tachycardia, and as well as we will also be able to decide the ectopic pacemakers, right? That is multifocal atrial rhythm. And then based on the P wave morphology, we can decide atrial fibrillation and as well as the atrial flutter. And lastly, one important point related to your pseudo P pulmonale. So these are the points what you need to know about the P wave abnormalities. Thank you very much.